different view. And what I want to do is just go over some literature and then rapidly transition into a few case examples. Here are my disclosures. So in the Western Hemisphere, about 10% of strokes, and in other parts of the world, up to 50% of strokes are ICAD. The US, we believe, about 100,000 cases per year. And it tends to be a complicated disease caused by either atheroembolism from large vessel to large vessel or hypoperfusion or a combination of both of these. And so this has been treated with every modality, medical as well as surgical, endovascular as well as microsurgical. And it's a little unclear as to what's the best way to deal with this. The medical history was very ominous when we first systematically looked at it in the WASIT trial, where exorbitant doses of aspirin were used with no particular benefit. And then SAMPRIS and VISIT were two contemporaneous trials, one using angioplasty followed by self-expanding stent strategy, the other one balloon-mounted stent strategy. And they both unfortunately failed, except they did show that the medical therapy, aggressive medical therapy, still had annual stroke rates of 12 to 15%. The unique problem that we are dealing with in the cerebrovascular is the fact that, unlike other peripheral vascular territories which were originally designed for some of these devices, we have a lot less intima, media, and adventitia, a lot more smooth muscle, and a lot more perforators and unique parts of the vessels which are encased in bone. So the two big trials that we have thus far, all ancient trials based on all the novel technology development, 2014 to 2015, showed that the stroke rate in the interventional arm was 15 to 20% in SAMPRIS and 24 to 36% in VISIT. And now people sometimes believe that this is the difference between self-expanding versus balloon-mounted, but there's a lot of controversy there because some people allocate this to less experienced versus more experienced centers. Regardless, both interventional methodologies failed to demonstrate any equivalency, far be it from superiority to the medical arm. So when you look at that, and all of this risk was early, 2 to 6 days after the procedure, all the complications were done. So if you could get the procedure safer, there was going to be value, but unfortunately, we never got there. Now, this is the Mori classification. Clearly, we understand it's not just a matter of interventionalist or device, but it's also a matter of the lesion, where Mori Cs are so much more complicated, very high risk of complication, very high risk of restenosis, and least likely to benefit compared to an A. So what do we do? Let's just transition to our philosophy. This is what I do, and I do it still currently, is that if the initial presentation is arterioembolic, then there's nothing interventional I can do right now that I believe has demonstrated superiority. And so this is a matter of maximum medical therapy. Many times we'll start them on dual antiplatelets and even leave them on a heparin drip for 24 to 48 hours and then discontinue that as long as the exam remains stable. However, if there is hypoperfusion, and how do you demonstrate hypoperfusion? We have breath holding index TCDs. We do CT perfusion with and without Diamox. And then there's the clinical sequelae or watershed infarcts on MRI, or a combination of all of these. Then what we do is we try to attempt maximum medical therapy with permissive hypertension and confirm the vascular reserve. And if the patient is symptomatic and clearly has a compromised reserve, then we proceed with submaximal angioplasty. And we typically leave them on, as I mentioned, on a heparin drip till we know which way we're going to go. Or if a patient has aggressive medical therapy and recurs, then we consider submaximal. And if they fail a second time, or they have a recalcitrant lesion which collapses immediately, then we consider stenting. Follow-up is typically with CTA, NOVA, quantitative flow MRAs, as well as CT transcranial Dopplers. How do we do the procedure? We have the patient's therapeutic on aspirin and Plavix. I have to tell you, more and more, we really tailored this response to PRUs. And if we are not happy with the PRU, which is true for about 25 to 35% of our cases, we switch to Brilinta. Unfortunately, I would like prasugrel because prasugrel has a longer acting thing, is less reliant on patient compliance with twice daily medication usage. And therefore, you don't have to be concerned about missing 2 doses and having no antiplatelet function. Unfortunately, prasugrel in the US comes with a black box warning to not be used with anybody with TIA or stroke. And so that entirely removes this entire population. We try to do these procedures under conscious sedation so the patient does not lose their ability to auto-regulate. It may make you cringe, but you should try it. It's actually quite efficient and effective. And then we use nylon balloons. The two that I am using are Mini Trek and Emerge. They come in both rapid exchange as well as over-the-wire categories, and they go all the way down to 1.25 millimeters. So really quite small. They have very good profile, and without the RX, they're really quite easy to track without extensive need for intermediate catheters. So for instance, most of our cases, we have a 6 French guide. We typically use benchmark and use no intermediate catheters to do this. Now, depending on where we are, specifically if it's a more proximal lesion and it's the carotid, then we'll use balloon guides to be able to inflate and flow arrest and aspirate immediately post angioplasty to make sure we don't have distal embolization. And we can do this without too much prolonged problems. So we have looked at this both in terms of our stroke rate, and this is the paper that we wrote, just contemporaneous sample size. I believe this was somewhere close to 50 patients that were not enrolled in SAMPER, so visit, and we participated in both of them. And it gave us a 4% peri-procedural and a 6% annual stroke rate, which is quite impressive. And then we did this large meta-analysis of submaximal angioplasty alone, and a large cohort. So this is now 400 patients. And what is important is stroke or death was 5% in under 30 days and 4% above. So still better than the best medical therapy under aggressive observation and monitoring as was done in VISIT and SAMPRESS. Submaximal appears better. So a couple of cases just to show you how we do this, and this may be of interest to you, is we learned from our cardiologists. They were doing no longer angiographic assessment of lesions because they believed, as has been shown in the cardiology literature, that they were massively over-treating patients who didn't need it. So they use what is called IFR or FFR, which is a fractional flow reserve. If you want to do FFR, you really need to sort of hemodynamically stress with adenosine or some other capillary bed injection. We simply are doing free ratio measurement of distal to proximal. For those who are interested, FFR typically is considered hemodynamically significant if the distal pressure beyond the lesion is less than 80% of proximal. That's the criteria cardiologists use. We are doing this in humans, so we were not really using it as a criteria, just recording it and using the pressure wire. So how do we do it? This is a good example. I'm going to turn this video on, and then I will turn my speaker off. This is a case of measurement of instant polarization and a CT perfusion the following day. Give me 1 second. I'm going to turn my mic off so I can speak through. There we go. Okay, so this is an example, And this is a patient who comes in with 70-year-old with aphasia, right upper extremity, with drift, facial droop, failed dual antiplatelet therapy for left MC intracranial atherosclerosis. So this is the example where we believe that this may be atheroembolic, gets placed on dual antiplatelet therapy, has mild right drift. CT stroke shows about 70% left M1 stenosis with increased time to peak. So let's see what the imaging looks like here. And there you can see on the 4D CTA, looks like tandem MCA lesions. And here's perfusion defect showing massively increased time to peak, but preserved volume and flow. And so this is a watershed infarct pattern on DWI. So this is somebody we believe would be a good candidate. So this is now a radial procedure, 6-French benchmark, and then simply SL10 microcatheter to cross the lesion, a synchro wire to help cross the lesion, and then we deliver the volcano FFR pressure wire through the SL10 because it's too stiff to do primary navigation. That's how cardiologists use it. And then we use a mini Trek non-compliant over-the-wire angioplasty balloon for the actual angioplasty itself. So let's just quickly go. This is what the wire looks like. And the pressure sensor is at the junction of the radio-opaque and the radiolucent parts. And so this is radial access. There you can see we're using a select catheter, and the benchmark is being advanced. When we get into place, there's the angiogram showing the lesions. There you can see, and still there are 2 lesions. And then we get a slightly higher mag. And once we have that in place, the first thing we do is we zero the guide wire through the guide. So we know what our arterial pressure is. It needs to be zeroed. So here the zeroing has been done, and with PDPA is 1. So that means distal over proximal is 1. So this is now zeroed. And then what we do is we cross the lesion with SL10 and a synchro, the traditional neuro tool. So we know that we're going to be safe. We make sure we go well distal. And once we are there, then we take the micro wire out and we deliver the actual pressure wire. Remember, this is the transducer. So you want to put it distal to the lesions where you are. And then we simply unsheath the SL10 and leave this in place. And now this pressure wire becomes the way by which our workhorse to deliver tool. And look at this. This is, again, let me stop there for a second. So PD or PA or FFR in this instance also, because it's instantaneous rather than based on any post-dilatation, and you are getting 0.23. So 0.23 is the difference, and this is a 14,000 wire through the lumen. So obviously some contribution of the wire going through, but really shows you how severe that is. So once we have that in place, then what we do in this instance is we go up with a balloon and then angioplasty the balloon. We go 1 atmosphere every 30 seconds and deflate 1 atmosphere every 15 seconds. And this is the immediate result. And then what we do is we do another slightly more proximal plasty to make sure that we have it good. And this is immediate post-result, 0.89. So you can see immediate improvement in flow. However, once the wire is taken out, you'll see the wire is being removed. We do another run, and I'll stop it there and make sure that we can evaluate it. So some improvement, but not perfect, not much. A lot less than 80%, I would say. But flow is proportional to the 4th power of the radius, the 4th power. And so a little bit of increment in flow is all that is needed. This is a lot more safer because there's no, there are lenticular striates coming off of there. You're not compromising them. And I believe that is the singular reason angioplasty is an excellent option when it comes to intracranial circulations, where, this is the final result and we're quite happy with it. Okay, so now let's change the situation. Let's show you a slightly different case. This is now, I'm going to stop the sound here again as well. And so this is somebody who comes in, right hemiparesis, right facial, found to have left M1 thrombus versus high grade. So this is an acute presentation, presenting with a acute stroke. And so let's see what imaging we have here. This is perfusion, which shows increased time to peak throughout the left hemisphere. And we then go ahead and look at the CTA. And let's play the CTA out. There you can see the lesions, almost identical. Believe me, this is not the same case. This is somebody who was having cardiac arrhythmia at the same time. So we call cardiologists and they put in a pacemaker. And there again, you can see a nice M1 stenosis that is there. So what do we do in this instance? Just because we're not sure whether it's thrombus or stenosis, go up to the lesion, do not cross it, and bring a large bore aspiration catheter. In this instance, I believe it's the red 72 penumbra system. There is the aspiration catheter coming up to the lesion, and then we aspirate and make sure it's not thrombus. If it's thrombus, it will hopefully come out. And then we do an angiogram, and we see it better. We see some more perforators. It could be just a better injection, but there we believe it's an intracranial athero. And so what we do is this is obviously slightly high speed. We're crossing the lesion with a wire, and now we're bringing a mini Trek, I believe, again, a 2 by 8 millimeter balloon, and we're going to do angioplasty. Again, this is acute stroke. The patient is awake, and this is the final plasty result, and slightly improved flow. No IFR here, acute stroke setting, no time to futz around, and normalization of the perfusion defect, and with the small M3 distal deficit. And then final case here is a patient who comes in with a slightly low NIH, but an occlusion of the right M1, and there was concern that there may still be a possible channel. So what we do is, in this instance, there we go. And NIHSS is only 3. And so what we do here is we see a distal M1 occlusion, which is there. And there you can see, it looks like this is the lesion which is out there, right there, is that inferior trunk is compromised. And so what we do here is we go ahead and try to do angioplasty of this. Actually, this is an occlusion, so this is started off with a stroke. Apologize, this is exactly, and it's another presentation of this patient who comes in with acute stroke. So embotrap is being deployed. It's a stent retriever in the inferior trunk, and then the run is done, and you can see some improvement in flow. Unfortunately, the patient did not get better or was left on heparin, and 48 hours later, it looked like the patient was not getting better, still had preserved volume and flow, and so the patient is brought back to the cath lab and see if there's submaximal angioplasty we can do for this lesion. And so this is, again, benchmark. This time it's femoral access. So again, you can see we're not really using intermediate catheters for plasty. However, in this case, it turns into stenting, and that's where the Sophia 5 French 125 adjunctional guide comes in. So the perfusion defect is no better, but there's still preservation of flow and volume. It's not too bad. I think we can still go ahead and do this. This is almost identical to the original presentation. And so this is where we are getting very close. We are crossing the lesion like we did the last time around, no different there, and get into a distal location. We are now bringing our devices close. There's our benchmark in the proximal. Submaximal angioplasty is now being performed with the mini Trek. And once that is done, then we try to do an assessment to see if we are any better off. And you can see the intermediate catheter is there too. And there's just not enough improvement in flow. We believe this is a recalcitrant lesion, even though it opens up with the balloon in place. Now the balloon is removed using exchange. We have our intermediate catheter ready to go. And so we are prepared what we need to do. And now a coronary stent through the intermediate catheter delivers extremely easily. And now you can, with this, we can really make sure we are going to line it up exactly where we need to. And then we never prep these. We slowly inflate the balloon, make sure that it's in the right place. And then again, this is immediate recanalization of flow. And this is the final result showing a much better improvement of the flow and normalization of the perfusion, which is really, and there you can see on the 4D CTA. So with that, I will stop, and I'll stop sharing here, and happy to go back and go to our screen and take any questions.
Thank you very much, Adnan, for this very comprehensive and interesting talk. So as we're way over time, I would suggest to go for one short question and then proceed to the next speaker.
Sounds good.
Yeah, Professor Eckert has one question.
Thank you very much for these good ideas to treat these patients. What about the antiplatelet with balloon only? Is this different from stenting?
So anytime, so we typically use for non-interventional ICAD. So a patient comes in, they get started with aspirin Plavix, their PRUs are performed, and if they are subtherapeutic, then they are switched over typically to ticagrelor. That is our agent of choice just because of that FDA label that compromises our ability to use prasugrel routinely. However, if it's an interventional patient, I have stopped using Plavix in patients where I'm going to do anything intracranial. I put them directly on ticagrelor, just because of the high resistance rate and especially the acuity. There's just not enough time. The loading period with the pharmacokinetics with Plavix are up to 4 hours. With ticagrelor, it's 30 minutes. So I think there are a lot of different value. And then earlier somebody mentioned this. There's only one reason we don't use cangrelor. It's the cost. And the cost is a lot higher than integralin in our institution. So that is, unfortunately, they sell the discounted version to Italy and then the more expensive version to the US. So unfortunately, we are unable to take advantage of what I believe is an excellent choice, because you can turn it on, turn it off. It has all the things that we are always looking for, rather than even with ticagrelor, you have a 12-hour half-life. So in case there's a hemorrhagic complication with cangrelor, you can turn it off and take them to the OR. You can't do it with Brilinta.
Thank you. Thank you very much.